Good afternoon. Welcome to the second session of the Feeding Assistant Training Series. Just a few housekeeping things before I hand it over to our speakers for today. All your phone lines are muted at this point. If you need to ask a question or you have a comment, can't hear us, just let us know by using the chat pane on the right-hand side of your screen, and we'll try and get those questions answered for you. Also, per the state and federal regulations, someone at your facility should be tracking attendance for this series. We have a template attendance form on our website, vanderbiltpsa.org, under the Training Toolkit page. And that website and all our other contact information will be at the end of the presentation. So at this point, I'd like to hand it over to our presenters for the day from Vanderbilt Center for Human Nutrition. We have Dr. Heidi Silver and Mrs. Abby Hudson.
Hi, my name is Abby Hudson, and I am a registered dietitian nutritionist. I work at the Vanderbilt Center for Human Nutrition under Dr. Silver. My primary roles there have been dietary assessment and nutrition education. I work with research participants in clinical, community, and in long-term care settings.
And I'm Dr. Heidi Silver. I've been at Vanderbilt for the past 13 years. I was in clinical practice as a nutrition support dietitian for the first part of my career. And now as a clinical researcher, I work to investigate the effects of different types of diets and nutrients like fats and carbohydrates and their effects in disease and in processes that are common to many diseases like inflammation and insulin resistance.
We encourage questions over our presentation, but we'll wait to the end of the presentation to answer any of those questions. So we'll start off with, why is nutrition important? In order for our bodies to function properly and to stay healthy, it is important that we follow a good, nutritious diet. Energy and nutrients that come from the foods that we eat and drink help us maintain our health, prevent injury and disease, and also manage chronic illness. Components for good nutrition include whole foods, which are foods that have been processed or refined as little as possible and are free from additives or other artificial substances. Variety, since foods vary in calories and nutrients. No single food or food group can supply all the nutrients a person needs. Balance and consistency of foods from each of the food groups helps us ensure that our body is getting the proper nutrients, vitamins, and minerals. Adequate fluid intake helps us prevent constipation and dehydration, which can lead to other health complications. And adequate vitamin and minerals. Without adequate amounts, deficiencies can occur and lead to a variety of health problems, such as weak bones and decreased immune system. There are many risk factors for poor nutrition. Typical long-term care residents have multiple risk factors for poor nutrition. Those major risk factors are age. With advanced age, a person can become more vulnerable to poor nutrition. Just the process of aging can affect digestion and absorption of nutrients. Physical inactivity, a person may be bedbound or disabled. Illness or injury. Diarrhea or fever, causing a person not wanting to eat or drink, being fatigued or tired, poor or decreased appetite, sense of taste and smell, which naturally declines as we get older, or sometimes certain medications can influence taste and make food less appetizing, missing teeth or loose dentures. When teeth are loose or missing, or if a person does have dentures, eating certain kinds of foods may bring pain. Impaired memory or cognition. Residents may forget that they have or haven't eaten, or they may not recognize the foods being served. Loneliness or depression, which can cause anger or frustration, that lasts for more than a couple of weeks, pain or discomfort, or lack of physical or verbal assistance with meals. Poor nutrition can impair our daily health and well-being and reduce our ability to lead an enjoyable and active lifestyle and cause a number of negative outcomes. Some of these outcomes are increased risk of infection, exacerbate chronic illness, loss of muscle mass and physical strength, slows wound healing, irregular bowel movements such as constipation or diarrhea, falls and fractures, and poor quality of life. When a person is not getting enough food or not getting the right amount or sort of food, malnutrition or being at risk for malnutrition can occur. A malnourished person finds that their body has difficulty doing normal things such as growing and resisting illness or disease. Malnutrition can occur at any body weight. A person can be overweight or obese and still be malnourished. Signs of malnutrition are poor appetite. Person may eat less than 3/4 of meals or snacks. Difficulty chewing or swallowing. That could possibly be from ill-fitting dentures or missing teeth or disease. Skin breakdown, delayed wound healing, cracked skin, dry skin, hair loss. Skin naturally becomes thin and fragile as we get older. Weight loss that is unintentional, usually a 10% weight loss over a 6-month period of time. Muscle mass loss and fat mass loss from restricted movement. Residents may possibly be confined to a bed. Fluid accumulation or edema or swelling as seen in the picture, which can be very painful. In addition, dehydration is a concern and occurs when your body does not have much water and fluids as it should. A person might not drink enough fluids because they don't feel like eating or drinking because they have been sick. They may be nauseated or have a sore throat or mouth sores. Some signs of dehydration are dry and cracked lips, dry, flaky, cracked skin, sunken eyes, being fatigued, feeling tired, or lack of energy. Their tongue may be thick and coated white. They may be confused, have constipation, or have low urine output. A person's diet is significant in the prevention and treatment of disease. Diet is defined as the amount and types of foods and beverages that a person consumes. Residents in long-term care have orders for a specific diet that indicates the amount and types of foods. A resident's diet orders are located in their medical chart and on his or her meal ticket. Some facilities may also have their diet order list and snack chart posted in the main dining room. It is the registered dietitian nutritionist that will assess the resident and determine which diet is most appropriate for that resident. In choosing the most appropriate diet, the RDN will consider eating problems, health needs, nutrient needs, and individual preferences. Sometimes the speech therapist will also have a role in assessing the type of diet when there are swallowing problems present. And now Dr. Silver will go into more detail about the main types of diet seen in long-term care.
So today I'm going to go over some of the main types of diets that are most frequently seen. The regular diet, where all foods and beverages are allowed to the individual in the long-term care setting and there are no restrictions. What is known as a texture-modified diet, a thickened liquid diet, some of the therapeutic diets we commonly see, and some of the adaptive equipment frequently used to assist individual patients with their food and beverage intake. I'm going to start with texture-modified diets. There are mainly two types of texture-modified diets. One is called a mechanical soft diet, As you can see in the food on the scale on the right of the screen, this is when meats or other foods are chopped or ground, and vegetables are cooked soft enough to be able to mash them with a fork. Because of this need for foods being soft and the texture changed to allow it to be easier to swallow, some foods are not allowed in a mechanical soft diet. Usually this is fresh fruit or vegetables that have a tough skin, like a plum, dried fruits like apricots, hard rolls or bagels or breadsticks, popcorn, bacon, and nuts. These are crunchy foods and often difficult to chew or swallow. Deep-fried, crispy foods, and also desserts that have dried fruits or nuts inside them, as well as chips like potato chips or snack chips. Again, these are crunchy foods, and they cannot be chopped or ground into this soft, mashed consistency. In the pureed diet, the food is processed even more, usually in a blender or a food processor. And then the food has a consistency of very soft mashed potatoes, applesauce, pudding, oatmeal, or refried beans, much like the consistency in the picture on the lower right. There are also some commercially prepared pureed foods. These often come in the form of the pureed food, which doesn't quite look like the shape of the original food, but is in a pre-existing fashion and can be eaten right away. We also have a diet called a thickened liquid diet, and there are 4 types of thickened liquids. Thickened liquids are usually consumed by individuals who would cough or choke when there is a thin liquid. Thin liquids are water, coffee, tea, soda, ices like a popsicle, lemonade, and juice that is thin and clear so it does not have pulp or fiber. Then we have nectar-like liquids, and these are liquids that have been thickened a bit to a consistency that would coat and drip right off a spoon. It's similar to what Jell-O looks like when it has not set firm yet. In our honey-like thickened liquids, the liquids have been thickened more, and it's a consistency like thick honey. As you can see from the spoon, the liquid would flow right off in a ribbon, just like actual honey would, when you try to drip it off the edge of a spoon. And finally, we have spoon-thick liquids. And these have been thickened so much that they are a consistency like a pudding. And they would remain on the spoon in a soft mass. Therapeutic diets are designed to meet the specific nutrient needs of a resident who has an illness or injury or chronic disease. With therapeutic diets, the regular diet has been altered or changed so that it can meet the specific nutrient needs of the resident's health problem and their health condition. Sometimes the nutrients might be the calories, or it might be the protein, or it might be a vitamin or mineral, or it might be the water content of the diet. I'm going to talk today about a few types of very common therapeutic diets. One of the most common is the diabetic diet, which also can be called a carbohydrate-controlled diet or a no added sweets diet. Next, I'm going to talk about no added salt diets, and these might also be called a low sodium or a low salt diet. Third, I'll talk about the renal diet, and then fluid restricted diets, and then some diets that are specific to individual long-term care facilities. The diabetic diet, which as I mentioned, might also be called a controlled carbohydrate diet or a no added sweets diet, is most often used for residents who have been diagnosed with diabetes. And this diet has been designed to control or keep their blood glucose or blood sugar level at a certain amount in the blood. To do this, the portion sizes of foods that are high in carbohydrate, that is, foods that are high in starch or sugar, are usually smaller than you would typically see on a regular diet. This also means that for desserts or sweeter items, the smaller portion size is used. In this diet, we often use sugar substitutes to allow the person to have the sweet flavor or taste of a food, but still be able to control the level of glucose or sugar in the blood. On the no added salt diet, which is also called a low sodium or low salt diet, this is typically used for residents who have high blood pressure, which is also called hypertension, or for those who have certain types of heart disease. For the most part, it is a regular diet, except that no salt is added to foods when they are being prepared or cooked or consumed. Because of this, you will typically not see a salt packet or a salt shaker on the tray or at the table, because this added salt is not allowed with the residents' meals or snacks. It also means that foods that are high in sodium or high in salt are not used. In the renal diet, we use this diet for our residents who have a diagnosis of chronic kidney disease or for those who are getting dialysis. And this is because the kidneys are not able to filter urine and function normally. So we have a special diet that restricts the nutrients that are difficult for the kidneys to filter. These nutrients are potassium, which is found in foods like bananas and oranges and tomatoes, phosphorus, which is found in foods like meats and processed deli meats and sodas and milk and other dairy products, sodium, which I previously mentioned for the low salt diet, and the total amount of fluid, including water, that the resident who has chronic kidney disease or is on dialysis is also restricted. The reason that these nutrients are restricted is because too much of these nutrients can cause severe problems with the kidneys, with the heart. It can also cause what's known as edema or fluid retention, and it can cause bone loss. So we work hard to avoid the foods that are high in potassium, phosphorus, sodium, and fluid. In a fluid-restricted diet, we have different amounts based on the individual resident of the total fluid that they can consume. A fluid is anything that is liquid at room temperature, including water or soup, broth-based soups, ice cream, popsicles, gravy, sauces, and Jell-O are all considered fluids because they all have a high water content. We typically use a fluid-restricted diet for residents with end-stage kidney disease, congestive heart failure, liver disease, or those who have what's known as hyponatremia, a low blood level of sodium. As I mentioned before, the amount of fluid that the resident can consume is different based on each individual resident's condition. It is very important with the fluid-restricted diet to always check with the nursing staff before you offer any fluids or additional glasses of water or coffee or tea or any other beverage to the resident to see how much they are allowed each day. There are also some diets known as facility-specific, meaning that particular facility that you work in or provide care in might have some special diets that they are the only ones who use. There are two very common facility-specific diets. One is the fortified food diet, and this is used when foods are changed by adding ingredients to increase the calories or the protein or both the calories and protein. And so they may be called a high protein, high calorie, or a high calorie, or a high protein diet. Residents receive these fortified meals on a regular basis to boost the amount of calories and protein that they take in. Most commonly, the foods that are fortified are foods like oatmeal and dessert items. There is another facility-specific diet called SMP, or the red napkin diet. And this is when silverware is wrapped in a red napkin on the tray or at the table. This is a sign that this resident needs additional assistance with feeding to be able to consume the foods and beverages that are served to them. I want to mention a word about snacks, because we often like to provide snacks as a source of additional calories or protein or other vitamins and minerals. It's important if you bring in snacks or go and get snacks from the kitchen to offer to a resident that you make sure that the snack type is consistent with the type of diet order that the resident has. Snacks can be foods or beverages, and snacks often help residents meet their energy and nutrient needs. But for example, if an individual is on a texture-modified diet, then we would want to make sure that the type of snack we provide is something like a pudding or a soft food item, so that it is consistent with the diet order. And now some adaptive equipment that we use to assist the resident. In the top row, we see what's called a weighted insulated mug. And this is helpful for individuals who have hand tremors or shakiness or Parkinson's disease, for example. The mug is weighted to be heavier to make it easier to hold on to and not spill beverages. We also, in the middle row, have something called a Kennedy cup. And this is a more lightweight cup than the weighted insulated mug, but it is also spill-proof because it has a cover and a straw. And so it's easier for some individuals to get the beverage into their mouth. And in the bottom row, we have what's called a no-tip cup holder. And that prevents the cup from tipping over and spilling. Some other adaptive equipment that you could commonly find in the kitchen to provide assistance to the residents you are working with or taking care of. In the top row, we have some cutlery that is built up so that it's angled. And this is often used for individuals that have limited movement in their arms or hands. It makes it easier for them to bring the food at an angle up to the mouth, and therefore the food doesn't spill. We also have utensils that have been weighted, and you can see in the bottom row the handles of these utensils is bigger than a typical fork or knife or spoon. This additional weight also helps steady the hands so that if the resident has tremors or shakiness, they can hold on to their fork or knife or spoon more easily. In this next slide, we see some different plate types. On the top row, we have a divided plate. Often this makes it easier for persons who have problems with their coordination to be able to get a particular food item onto their fork or spoon. And residents who might have the use of just one hand, that they're able to scoop the food up onto their fork or spoon more easily when it's divided. And in the bottom row, we have what's known as a food bumper or plate guard. And this is a very practical tool because it allows the resident to be able to use their fork or knife or spoon and push the food up against the guard or bumper so that the food doesn't get pushed right off of the plate. In this slide, we see in the top row some different types of bowls that are used. We have on the top row a bowl called a keep warm dish, and basically it just keeps something like soup warmer for a longer time than a regular bowl, and it's a good tool to use when a resident needs a longer time to be able to consume their whole food item. Someone that eats more slowly. And in the bottom row, we see a non-skid bowl. And this is used often for individuals who have problems with muscle strength and muscle dexterity, or who have difficulties with their vision, or who might only be using one hand. The dish is designed so that it will not slip and move around on a tray or table. And that keeps the food from spilling over, and therefore makes it easier for the resident to get all the food. There are some other things we need to consider when we are designing diets and choosing types of feeding assistance utensils for our residents. Our goal is to help our residents live their lives with dignity and respect, the same dignity and respect that we all want as we get older. And so aging often changes our bodies and our ability to taste and smell and handle foods in terms of our dexterity of our arms and our hands. But we usually don't like giving up our independence when we get old. So it's very common for residents who want to live their life with dignity and respect not to ask for help. And we have to find ways to be sensitive to the need for help without being intrusive, but also be sensitive enough to recognize when an individual needs help. So to best provide assistance, we have to be aware they may not ask for help, or they may say they really don't need help when in fact they do. And we have to be aware that they may not be getting adequate foods and beverages to meet their energy and fluid and nutrient needs to prevent dehydration and prevent malnutrition. In other words, like Hippocrates said, let food be thy medicine, and medicine be thy food. So now we're going to see if we have any questions.
And this is Dr. Simmons from session 1, and I just want to recap a couple of the things that our presenters shared with us today. First, as a trained feeding assistant, you should know that your only responsibility is to pay attention to an individual resident's prescribed diet order, which should be clearly noted on their meal tray ticket, or if you're not sure of a person's diet order, you should ask a supervisory nurse or someone in the kitchen to clarify. And the kitchen is responsible for presenting a meal tray to you or a snack item to you that's consistent with that diet order for an individual resident. So if you're going to help Mrs. Smith during lunch, you just want to make sure that when you sit down to help her with lunch, that you look at her meal ticket and make sure that what's on her tray matches that ticket. One of the most common errors that we've
seen is that somebody who does have an altered texture diet order will accidentally get a regular meal tray, for example, or vice versa. Somebody who has a regular diet order will get an altered texture meal tray. So those are the kinds of, you're not responsible for figuring out or trying to remember all these different diet orders because there are a lot of them. You're just responsible for making sure that what you're offering the resident matches their order. And I think that can be a little bit trickier if you're helping with between meal snacks. But again, the facility kitchen should be hopefully preparing those snack items for you and making sure that the items that they're giving you to offer individual residents are, again, consistent with their diet orders.
Again, if you have questions for our presenters, they're more than willing to answer. Just type them into the chat pane.
I'll actually offer one question for our presenters. It's been my experience that we don't see the use of adaptive equipment as much as you would think in this population. If a feeding assistant is noticing that a resident that they're helping might benefit from some of these different types of adaptive equipment devices, who would they talk to in their facility? Would the speech therapist be the most appropriate person to go to? Is that the person who decides? Or is it the facility dietitian? Because it seems like there's so many different options, and I could think of a number of residents who could benefit from those, but we don't typically see them used very often.
I think it depends on the nature of the problem. So the speech therapist is very much in touch with whether a resident's able to swallow foods and if they need any type of alteration of the diet for swallowing. But the assistive devices really aren't enabling swallowing. They're more physical tools in terms of dexterity and the ability to manually handle a fork or knife or spoon or, a plate or a bowl slipping around on a tray. So I think the best person to talk to first is the dietitian, so that if there has to be some kind of special order, the dietitian could communicate with the medical staff and orders written for assistive devices. And then the dietitian also could intervene with the kitchen staff and discuss with the kitchen manager or other food service staff what's available in that kitchen and what the needs are, and make that be part of what's provided with that individual diet.
So you will hear us say repeatedly throughout these sessions ways that we're encouraging you to ask questions, even following your training when you're actually helping residents, whether it's a question about whether or not their diet order seems appropriate, maybe they're getting a regular diet, but you notice when you're helping them they are having a lot of difficulty chewing and swallowing, or they might could benefit from the use of an assistive device, or as you heard in the session one, if they have pain complaints, especially in their mouth or ill-fitting dentures, never be hesitant or shy to go to your supervisory nurse or the facility dietitian and share some of your observations and experiences of what you're noticing about an individual resident when you're helping them to eat and drink. Because residents do change, their needs change over time. Diet orders can change over time, and how much help they need can change. And if you are routinely helping a resident to eat and drink, whether it's during meals or between meals, you're in an ideal position to notice those changes and to alert other staff appropriately.
Is there a difference between a diabetic diet for someone who's in long-term care versus someone who is living in the community, maybe by themselves?
So the goal of a diabetic diet is the same regardless of where you're living or how old you are or how long you've had diabetes. The main goal of a diabetic diet is to help control blood glucose, which is also called blood sugar. And so the amount and types of foods that the resident consumes alters their blood glucose or blood sugar level. So regardless of where you live or how old you are or how long you've had diabetes, the foods that are going to affect your blood glucose or blood sugar level the most are the foods that are high in carbohydrates. That is starches like pasta or rice or bread or bagels, sometimes even some of the fruits like bananas, and also the sweets, desserts, foods that have any sugar or sweetener like honey added to them. We often suggest that if a person likes the taste of sweet, that they use something that is a sugar substitute, like Splenda or Truvia or one of the other sugar substitutes, because those don't have the nutrient to alter the blood glucose or blood sugar level. And they can be used in baking or cooking or preparing foods.
Okay, we'll stay on the line for a few more minutes in case you have any questions, but I do want to let you know this session hopefully will be posted within a week to 10 days on Adam Alliance's Learning on Demand, and you can see the link there. The link is also on our website, vanderbiltpsa.org, and we'll be back next week after the holidays for our third session, and we'll have our geriatric nurse practitioner with us. If you have questions or comments, in the meantime, our contact information is there, phone number and email address.
And as Dr. Silver mentioned, certain facilities do have facility-specific special diets. So we encourage you to find out what those might be within your own facility by asking the registered dietitian for your facility. There might be some special diets that are used in the facility that you're working in that were not covered today, even though we did cover the most common types of diets. Well, thank you so much for joining us for session number 2, and we hope to see you back for session 3. Please spread the word in your facility about the availability of these sessions on the Q-Source On Demand for other interested staff who might not be able to join the live webinars. Thanks so much.